Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Today we have two guests talking specifically on the unionization of physicians. Our first guest is Bryan Haimes. He was raised in Minnesota and earned his bachelor's degree in chemistry and biology from St. Olaf College. After college, he spent time in Tacoma, Washington, working with AmeriCorps at the homeless clinic. He then pursued his Doctor of Medicine and Master's in Public Health with a focus on healthcare policy from the University of Miami's Miller School of Medicine. Bryan relocated here to Delaware to complete a combined residency in internal medicine and pediatrics at ChristianaCare and Nemours Hospital, Children's Hospital. Currently residing in Wilmington, Bryan works as an internal medicine hospitalist and pediatrician at ChristianaCare's Pediatric Care Center. He also has held leadership positions in quality improvement initiatives at ChristianaCare. He is actively involved in healthcare policy advocacy, holding positions in the Medical Society of Delaware and the American College of Physicians, where his focus is on public health and addressing the social determinants of health. Most recently, Bryan played a key role in organizing the ChristianaCare Physician Union, advocating for the well-being of his fellow physicians and the patients they serve. Bryan enjoys spending time with his family, volunteering with his dog, Professor Snap, through the therapy dog program, Paws for People, and staying active in the ultimate Frisbee community. Our second guest is Dr. Amber Higgins. Amber was raised in New Mexico. She attended the University of Puget Sound in Tacoma, Washington, where she received and earned her bachelor's degree in science. She spent a year working as an emergency department scribe at Santa Fe, New Mexico, where she fell in love with emergency medicine. After medical school, Dr. Higgins moved to Delaware to attend ChristianaCare's emergency medicine and family medicine residency. She completed 5 years of combined training with an additional focus on women's health and obstetrics. She now works as an attending physician at ChristianaCare, splitting her time between emergency medicine and obstetrics and gynecology. For the last year, Amber joined the efforts of her colleagues to organize the largest and first private attending physician union on the East Coast, and now participates in bargaining to create ChristianaCare Physicians Union's first collective bargaining agreement. Improving patient care and securing the future of irreplaceable physician-patient relationships are her guiding goals in the work with her union. Amber also is dedicated mother of three, with a fourth on the way in August, and enjoys spending time with her family on their farm, gardening, horseback riding, and foraging for wild foods. Welcome. Now, before we start questioning how the union was formed, what's the purpose of your union, I'd like to go over what the American Medical Association has commented on unionization of physicians in the United States. The American Medical Association has historically had a cautious and somewhat ambivalent stance on the unionization of physicians. While the AMA recognized physicians' rights to organize and advocate collectively, it has not been an outright proponent of unionization in the traditional sense of union labor, especially for physicians in private practice or those who view themselves as independent professionals rather than employees. The key points in the AMA's position is they do support collective advocacy. The AMA supports physicians' ability to engage in collective bargaining, especially for employed physicians and those working in large healthcare systems, to negotiate for better working conditions, fair contracts, and to advocate for patient care improvements. Physician independence is another issue the AMA wanted to keep and emphasize. Preserving physician autonomy and the physician-patient relationship, which is sometimes viewed as potentially complicated by traditional union frameworks. Legally, the AMA has pushed for legal reforms that would allow physicians, particularly those in small groups or independent practice, to engage in collective negotiations with health insurers, arguing that current antitrust laws disadvantage them compared to large insurance entities. For example, we're not allowed to go into that kind of a process if you're independent on the street or doing your own work. For example, they supported the legislation like Quality Healthcare Coalition Act, which sought to give physicians more leeway in collective negotiating issues. The AMA does not explicitly endorse or oppose physicians forming or joining traditional labor unions, especially when it concerns hospital-employed physicians or residents where unionization has become more common. Instead, it focuses on supporting mechanisms for physicians to advocate effectively within their work settings. Okay, so my first question is why did you pursue unionization of the hospital-based physicians? I'll start with Dr. Higgins. Amber?
Well, I think what really got the ball rolling with our physician union was when we started to really talk about how patient care had been impacted after COVID. Mm-hmm. We were seeing longer and longer wait times for patients to be seen in the emergency department. We were seeing more and more patients not able to get rooms. They were in hallway beds and then waiting longer and longer in the emergency department to get a room upstairs if they had been admitted. So from my perspective, working in the main emergency department, and then I also worked for Obstetrics and Gynecology, it was really more like a patient care issue that we kept asking administration to fix these things, help us out with more staffing, that sort of stuff, and it just didn't seem to be effective any longer after years of trying to pursue it that way. And then when we really started talking between ourselves and other departments, we found that everyone was having the same issues. They were all sharing the same burdens, concerns for patient care. And that's what kind of ended up unifying us together initially.
So This was all based upon the patient's benefits to the patients in that regard, correct?
Yeah. I mean, honestly, when I would reach out to people, talk about, oh, hey, look, we're thinking about unionizing, that's really what they wanted to talk about. Like, really, how is, working together, how can we fix these problems with staffing support, with, having enough physicians to see all the patients that are there to cover the shifts, the people who are coming, because we've had a huge breakdown in separate from hospital medicine, a huge breakdown in our primary care structure. And the hospital is now where almost everyone ends up getting their care in the emergency department or inpatient.
Believe me, primary care is suffering throughout this country, and I've done a bit of an editorial on that issue too. I believe personally that primary care is the foundation of medicine. I'm a primary care physician of 45 years, and I think we are the foundation of good medicine, and when the foundation crumbles, the house falls down. So we don't want to see it go any further in the bad direction. We're trying to make corrections and see what we can do as primary care physicians to bolster our numbers. I think I heard, this might not be the accurate number, but I heard that out of all of the, where the residents trying to get matched, where the doctors coming out of med school try to get matched, there's like 350 unmatched primary care seats, and that's a shame. I teach students in my office commonly and regularly, and the students have said that they don't want to go into primary care. The ones I treat, one wants to be a psychiatrist, one wants to be an anesthesiologist, etc. And they lose sight of the fact that they're still physicians and they have to do, the work that we do as physicians, and that we need more of us to keep things running properly. I say for every dollar spent, they save $9. If you have a primary care doctor, you'll save $9 to every dollar spent in medicine. Yet we seem to have doors closed to us all the time to help encourage medical students who are completing their 4 years to go into primary care for many other reasons. but they cannot afford the reimbursement that we receive for primary care, coming out of medical school with a $250,000, $300,000 debt. Okay. Now, how do you answer that question, Dr. Haimes or Bryan?
So I work as the primary care physician within the hospital as a hospitalist, and I started in 2020 right at the dawn of the pandemic, and when I was going out throughout residency, I focused a lot of my time and training on quality improvement and really just improving patient outcomes, finding ways to work within the hospital system to make things happen more efficiently, improve outcomes for patients. And I found that when I first started with the Hospitalist group that we had a lot of voice within certain committees. We had the ability to give feedback, and we had the ability to actually create change, whether it was on the front line in the way we took care of patients, whether it was the way we were scheduled just so that everybody would be fresh and we would actually hit patients and take care of patients when there was that influx of patients. And anytime a problem arose, they actually came to us as the people working on the front line to help them brainstorm. And I found that over the 2, 3, 4 years of the pandemic, as it started to drag out, they started to make a lot more decisions and then start to tell us what those decisions were, rather than give us any sort of feedback mechanism or ability to actually say, hey, these are the problems that we run into. And so it was really the top-down decision-making that really affected our ability to take care of patients in a good quality way, because that's what we want, is good patient outcomes.
What made you go into hospital medicine, being a hospitalist, as opposed to setting up a practice? I'm independent on the street.
Part of it is the schedule. I really enjoyed the shift work aspect of it, and it allowed for some flexibility in my life to maintain a good work-life balance.
Family, business.
And as an internist, I got used to taking care of some of the sickest patients, working in the ICUs, and so I'm all for taking care of those healthy patients, but I like to meet patients when they are at their sickest and get them through that and help get their families through that as well.
Good. Now, either one of you can answer this one. How has it been received by the hospital administration? Anybody want to take that one and run with it?
Sure. Well, I mean, I think initially it was certainly, there was a lot of adversarial language. There was a lot of meetings with different departments trying to discourage individual physicians from voting for the union. I wouldn't say threats, but specifically just, language around like, well, doom and gloom sort of stuff. If you unionize, all of these bad things will happen. That sort of kind of reception.
Like what bad things?
Like you'll lose your ability to negotiate your own contracts. You'll lose your ability to truly have autonomy because the union will take it over. You might even lose your ability to, like, clinically make, that sort of stuff because of pressure from the union itself.
And a lot of the messaging they pushed was every physician is now going to be equal, even though we are all different specialties.
Or not even just equal. Every physician will have the same, like, cardiology and nephrology and emergency medicine will all of a sudden now have the same exact work-life balance, same exact schedule, same exact financial, which just
isn't realistic.
Wasn't realistic at all.
I was just going to say that.
So that's never what anyone was looking to do. And our message to push back on that was, look, the union is what we create it to be. Like, it will be what we create it to be if we have a whole bunch of different physicians who are working together to make sure that the specialties are practicing in their most efficient way at the absolute top of their license. Then, and we're all supporting that in between each other. Like, that can only be a win-win situation.
I understand. How do you add anything to that?
Yeah, so negotiating my contract, I've had 3 with Christiana so far, and I've gotten them to change one thing in my individual negotiations, and that was when they spelled my name wrong. I got them to change my name to being spelled correctly.
So you're getting a bit of negative pushback on the whole situation.
Yeah,
correct?
Yeah, and I think it's turned around a little bit now that we've started actually bargaining. We have made some progress with the administration and some agreements during our bargaining process. There's still some adversarial language and still a lot of pushback, especially since the last election, but I think it's improved.
Has there been any legal pushback, formal legal pushback?
I wouldn't say, I mean, they have lawyers sitting on their side of the table. I wouldn't say that there's a ton of legal pushback, but anytime that we feel that they have done something that is illegal in the union's eyes, we work through the NLRB and file unfair labor practices, which is just a process to allow us to say, hey, we're part of a union now, you actually have to sit at the table and negotiate with us over these change in working conditions.
Understood.
Right.
How many physicians have joined, and does your numbers include nurse practitioners and physician assistants?
We're right around 500 of a multi-specialty union, and it includes anybody who works really more than 20% of their time within the hospital system in acute care. It does not include physician's assistants or nurse practitioners at this time, just MDs, DOs.
Would that be something in the future? To gain higher numbers?
So the way that the federal government defines like a work unit, for example, for inpatient medicine, that work unit, as my understanding, is actually defined as a physician unit. So the APCs, nurse practitioners, PAs, midwives are defined separately as a separate work unit. So those were structures that were already in place before.
Are they trying to divide and conquer here, or what?
I'm not too sure why the federal government designed it that way, but for outpatient physician unions, for example, right before we unionized Allina Health in Minnesota, they unionized their outpatient physician primary care workforce, and that actually, for the federal government, includes APCs and nurse practitioner APCs within that. So they were all there as a group, but we really had that structure defined for us.
So you had about 500, you said, right, Brian? Have there been any people that you've gone to and said, no, we don't want to join?
So there have been people who have been against the union, but they've definitely been in the minority amongst our fellow physicians.
Have they given you reasons?
Some of them are in such a small specialty that they feel like their voice would be lost in the scuffle of some of the larger specialties, like the Hospitalist group, which is about 150 to 170 physicians. And the biggest thing that we always communicated is this is about patient care, this is about working together, and we want to lift everybody up. And we want everybody to be able to practice better medicine and even just to maintain the things that we like about our jobs right now.
What you noted earlier when I asked about, why did you pursue this? It was all patient care. But in turn, isn't there a secondary benefit for the physicians that are working in this situation?
Well, I think there has to be, because patient care is, in this situation, what we're talking about, patients are taken care of by physicians, right? And if we want to have physicians in the future, we have to make sure that the reasons why people go into medicine, to have relationships with patients, be able to heal them, care for them, and be able to have a stable job in which you use your mind and your heart to their best ability, that those all still exist. So part of the union, is certainly having a secondary gain for making sure for the physician workforce is not burnt out, is willing to stay practicing clinically, right? Because we saw huge retirements and a huge wave of people leaving clinical practice during COVID. But that's been going on for a while. And even people just applying to medical school, wanting to become physicians, has decreased. So I think it's in everybody's best interest, both the patients and the physicians, that we improve patient care, improve our workforce, and make sure it's a sustainable profession.
Gotcha. You mentioned, go ahead.
I was going to say, and maintain physicians in Delaware and not make them want to leave the state, because we're a small state and a large portion of the physicians who are employed in the state are employed by ChristianaCare. And
that is true. That is true. When I first came out, 45 years ago, 85% of the doctors were independent.
Yeah.
Or maybe a couple doctors in a practice, but independent. It was a wonderful time. It was a lot different than it is today. Obviously, we've progressed with EMRs and things like that, which are burdensome, and prior authorizations, which you guys don't involve yourself with, do you?
Not usually.
Not in the emergency department.
Just stick in my office for one day, and you know what that's all about. I also did a podcast panning prior authorization, just to let you know. But let's go on now. What happens when the administration looks you in the eye and says, no, we're not doing this? What do? You demand X, and they say, no way.
Well, I think first we usually ask why.
Okay. And they give you a reason why we just can't afford it, we can't move, things like that, doesn't seem reasonable. They give you a bunch of word salad about how they can't do it. What do you guys do? And what do you say?
We do a lot of working together amongst ourselves, and so any bargaining session has time when we spend together sitting across the bargaining table, and time when we spend completely separate where we talk amongst ourselves as a group, and we brainstorm of like, what are we trying to get out of this, and why is it that the administration is so harsh against us? And if it is a particularly important issue for us, we stick with it. And there are ways to show our unified voice and our unified power to stick with those things that are most important.
Where's your power? What do you do? What do you do? Sticking with it is a good idea. Keep on banging on the door. Maybe they'll say, okay, after a while, and let you in. What do you do? The end of what I'm going to is end all be all unionization is you don't get what you want from your employer, the company, whatever. You go on strike. Now, strike is not in the best interest of the physician. I don't think you get many physicians that would do that. We cannot abandon our patients just to get something that we want out of the system. So striking would not be great. So what power do you have if you don't have that end power of saying, well, you don't give it to us, we're done?
Well, something that is actually I was thinking about in relation to the statement of the AMA, which was that part of it is that they support just collective action, coming together with different physicians, and that sort of group power is helpful, and that's something that you get in a union of all the physicians or a significant majority of physicians who work for our institution saying, no, we really support this, and that just gives you an automatic kind of some leverage there. But specifically, once you become a union, you have actual legal parameters around that negotiation. And you cannot go through what's called bad faith bargaining. So both sides, both the physician side and the employer side, have to engage in a discussion. They cannot just say, no, 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 no. There has to be some sort of agreement or working towards a mutual goal.
Have you had any no-nos?
Not yet, really. There hasn't been any issue where there's just been absolutely this, that we've been able to at least, if there was a really strong position, tie it to some other positions and kind of make a package deal or a negotiation in that way. And to address the strike issue, I don't think any physician that we have talked to at all in our union. That was a big question when before our election, like, well, what are you going to expect me to strike with you if you don't get what you want?
And I would argue that that's in current state, meaning we haven't gotten to a point where we feel so strongly about something that we would ever want to strike.
Yes.
I'm sure there's an issue out there, like if all of a sudden they made every physician work 160 hours a week. That
Bless you if you did.
Yeah. Or remove some
never,
amount of critical staffing.
They would
or
never
something
require
like
that because we have laws that say you have to have a certain period of time off. You can only work a certain amount of hours a week.
Right.
They weren't around when I was around. I remember sometimes I didn't sleep for 3 days. But that was the nature of the beast back then. And it's good that you now have some regulation over that because sleep deprivation makes you kind of quirky. Yeah. You get brain fog. You might not make the right decisions. But I see that and understand that.
So there's the bad faith bargaining piece. There's the strike, the strike and the collective movement, organized piece at the end of that. But in between that, there's a lot of other steps. which, we've not even had to go to, either, work slowdowns, stuff like that, stuff that wouldn't impact clinical care, but just might impact the administrative side of the hospital. That's something that, if we had to, we could go to.
Can you give me some instances where you've been successful in your negotiations?
Yeah, absolutely.
Give me a couple. Give me some.
So one of the clauses that we really wanted in there is called union security clause. And so what that says is it ensures that every person who becomes employed at the hospital who should be part of the union will be part of the union. And that just helps us to maintain integrity, maintain unity amongst the physicians, and really just helps us to maintain our strength as a union, and working together to really continue to advocate for patient care. And
has there been any physicians who said, look, you're not doing enough for me, I want out of the union, I don't want to be a union member any longer? No.
Well, not yet, because we haven't signed any collective bargaining agreement. So we're still all working in the negotiation part.
Okay.
But, I think that hopefully before they got to that point, we have a very open organizational structure where it's not just like the bargaining committee is running everything. We've got everyone is viewed as an equal in the union. And so hopefully they would be able to go to their colleagues or go to whatever person in their specialty was dealing more directly with the union and trying to negotiate something. And I want to say another piece that we've been really successful in negotiating is coming up with a grievance procedure. So before, if you had a problem with the administration, you had a problem with the contract, had a problem with patient care, you basically, you could send an email, you could state it in a committee, you could try as hard as you could, but there wasn't any formal procedure for addressing that problem.
So you said it and then it was forgotten when you left the room, right?
Yeah.
Mm-hmm.
But now we've gotten the administration and the union into an agreement with a specific process. You send this concern to the manager. They have to reply within a certain amount of time. Then if that's not resolved in that initial reply, then it goes up the chain to the point, where there's specific dates and specific structure that actually can address those concerns.
Sounds like you got this pretty well formulated. Have you taken any? Have there been any other hospitals that you've looked to say they have a successful program? Let's say, how did you do it? What have you gotten advice from other hospitals? And how many other hospitals do you think are doing this? I mean, it's all hospital-based, basically. Yeah. You're employed by a company, and yada yada yada. So you get to say, I can form a union and collective bargain. Has there been any hospitals you've taken advice for and they've been successful with?
I would say that there are very, very few large physician unions in the nation right now. Mm-hmm. There's a lot of different specialty groups out there that are like smaller groups. So we are the first large multi-specialty organization, especially in like the private sector. Mm-hmm. So the public sector in like DC or more like New York City, Chicago, have a lot of unions in the public-owned hospitals there. Okay. And so we get some advice from them, but it's just a different ballgame being in that large city.
So the first state is the first union, huh?
Yeah.
The first multi-specialty
inpatient
provider or attending union, because there's also several different multi-specialty resident unions. For example, that was talked about in the AMA. And then since we have unionized, I think we were kind of just on the front of a large wave of different hospitals, even private hospitals, that are having their attendings unionized. So apparently Doctors' Council, which is the overarching body that our union is organized through, their phones have been ringing off the hook.
Yeah. And
who heads up the union?
It depends on what you mean by heads up, because it's really
you have to have some kind of a head.
So we have no
physician head. We are all all the physicians in the union are equal. Anybody can come participate in the bargaining committee. Anybody can participate in the organizing committee. We do have a Doctors' Council appointed what was John August's title specifically?
So he's our chief negotiator.
Our chief negotiator. So
And what's his name?
John August, and he's out of Cornell actually, and he has a ton of experience being a negotiator for different unions, and he teaches about specifically.
He's not a physician, though.
He's
He's not a physician, but he's a professor at Cornell.
He's a negotiator.
And
And a labor relations expert.
Okay.
we're really lucky.
Yeah.
Now, where do the residents stand in this? They're not fully, they're physicians, but they're not able to go out and work yet.
So they are not part of our union, but they actually voted to form their own union in January.
Yeah,
How many residents are there?
that's it's a lot.
I would say about 200, 150 to 200.
Yeah.
So just in their practice, their group alone, they have half of what you guys gotten all together.
Yeah.
Interesting. Do you ever think this will filter down to us poor guys on the street?
Yeah, I think it may.
How may it do that? Would you please let me know? I'll be able to stand up and head that union. Go ahead. How would you do that?
Well, I mean, I think, first of all, the primary care and the outpatient sector of ChristianaCare, may in the future unionize. I think a lot of different areas of the hospital, including the APCs and the nurses and the residents to some extent before they had their election, were waiting to see what the results of the attending union would be.
Mm-hmm.
And I don't know the specific legal around independent physicians unionizing. It sounds like mainly it works from an employer structure, but I think certainly
I would say that,
coming together and having collective voice is very helpful.
If you're an independent practitioner and you currently have an issue with the way ChristianaCare does something, like how they communicate with you, how the physicians are taking care of your patients in the hospital, who do you go to now?
Nobody. Where do I go? I could call the administration. I have done that in the past. I won't say who I've spoken to, but I have, and it really didn't get me much. Didn't get me anywhere.
I would say one of the things with the physicians union is now we have broken down the silos within the hospital system, and we now have specialists talking to specialists, talking to hospitalists, and the communication is a lot more open. Mm-hmm. And if you want to talk to somebody about how to change something within the hospital, of hey, I have this great idea on how you can take care of these patients and how you can transition them back to primary care more easily, that's where we come into play.
I receive, I'm on staff at Christiana. I do not make rounds any longer, more of a courtesy staff. And my patients, as soon as they get in the hospital, they call me. And sometimes that's the only way I find out they're in the hospital. That's terrible. Then I go on to DIN and I get all the information I need about their hospitalization and know where they stand. And sometimes I may even call the hospitalist to say, Mrs. Jones is this way. I've known her for this many years. This stuff that she, this, that, and the other. And I give some information to you guys. In some ways I say, the hospitalists don't know that individual patient as well as the attending outside of the hospital. So I'll go and call you guys, and I have, and talk to you, say that this is a quirk that you got to work around with her or him, so that you know that you're looking forward to, you know what you're facing when you go in to see the patient. All right.
I would say that's invaluable as a hospitalist.
Why don't the hospitalists, this is one point. Dr. Jones has just put in Mary Smith's in CHF or whatever. She says, why don't the hospitalists get on the phone when Mary says, my doctor is Dr. Biasotto? Why don't you get on the phone right away and say, hey, Doc, what's been going on with her?
Yeah.
I mean, you do take a great history. I read them when I get them. You do take all the information, all the medications. But how come you don't talk to the person, excuse me, that knows them the best?
I think it's a time limitation for a lot of the hospitalists is they've continued to push more and more patients onto our lists and limited the amount of time we have to take care of them, and also limited the support staff that we have. And so there was this great role back in the day called PCFs, patient care facilitators, who worked on every unit, who were a liaison between the hospitalist, the nursing staff, the patient and social work and case management, and they really got to know the patients really well. And so sometimes they would make that call to really talk to the primary care physician.
That's what you should be doing. I think personally you would benefit the patients by talking to the doctors that have cared for them for years. That's a complaint I hear from many of our physicians.
Yeah.
I'm the president of the Newcastle County Physician Organization, and we have complaints that come to me from docs out there. We have a large group in that group, and I try to address these complaints. And then one of the bigger ones is that, this happens, and I didn't even know that patient had that. Why didn't they tell me? Why wasn't I? So we tried to take that to the administration before a union was created. So maybe we have a better foot in the door with you guys. What do you think?
And so we're trying to form this thing called a collaboration council, where there's multiple specialties that sit across from the hospital administration and continue to brainstorm about these issues that can improve patient care and improve just like the physician wellness, because me talking to you for 3 minutes is probably going to establish a much better rapport with that patient than spending a half an hour talking to the family.
Then take that back to your union and tell them that the docs out in the field, we're getting shot up. The doctors out in the field, we have to have some communication and better communication with the hospitalist, and obviously the hospital. I mean, the way I go about it now is Mary calls me, I call Mary back, and we have a long discussion. Well, who are you seeing? I don't know. I see 3 or 4 different doctors all day. I don't know. Did you get any of their names? No. Were any of them specialists? No, I think they work for the hospital. You should have been here, not them, is what they tell me. I said, well, we don't come there anymore because the hospital wants the hospitalist to run it. I think you would solve a great deal of problems by simply 5-minute call, 5 minutes.
Yeah.
I mean, I know you're pressed for time, but somebody has to do that.
Certainly, and I don't even think it's just between the hospitalists and private outpatient doctors. Right?
It's a what between?
I don't even think it's just a problem between the hospital medicine-based doctors and the private outpatient physicians, right? It's any primary care provider that we need to figure out a better way to organize the hospital team and the outpatient team together.
It would be wonderful.
To continue that care.
It would
because
be
there's
wonderful.
huge breakdowns on both sides.
In 5 minutes, I can
Right.
send you the entire chart. I can let you know what we've done.
Yeah.
Oh, we've already looked at that, and that's been totally negative. Why are you going to waste your time? Maybe save some money by not ordering that test, because I did it 3 weeks ago.
Right.
And it's not available on the DIN for some reason. You know what I mean?
And I think the electronic medical records were supposed to solve a lot of those issues, but I think they've just created more barriers
because they don't communicate.
No one is calling each other anymore.
I mean, I have Paradigm, and you have, what do you have now? Is it?
We have PowerChart.
Cerner.
Cerner.
Oh, yeah.
So, boom, I can't communicate direct. Here, boom, I had to press a button, the whole chart would come to you. Take about 2 minutes. Now I got to either send it by, fax or send it by email or whatever. So it would be wonderful if all of our PMR, what am I saying here? Our electronic medical records could communicate.
Yeah.
That would be a wonderful thing. I think it would solve a lot of problems, and it would be good for patient care. Okay. Let's take a brief break here, and then we'll be back with maybe a couple more questions before we end this on the unionization of physicians.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Yeah, this is Dr. Biasotto. We're back from our break, speaking with Dr. Bryan Haimes and Dr. Amber Higgins, who are sort of head muckety-mucks when it comes to the union that they're forming in the ChristianaCare. Now, another question is, do you have any other affiliations with your union outside of, obviously, the ChristianaCare union? Do you have any other affiliations that you tie with?
So we organize through an organization called Doctors Council, which sits under the overarching umbrella of the SEIU. The ICIU has more than 2 million members, and Doctors Council has...
What is ICIU?
SEIU.
Oh, SEIU.
Service Employees International Union.
Okay, that sounds good.
And
Okay, sorry to interrupt.
so ICIU has about 2 million members from like nurses, radiology techs, et cetera, et cetera. Doctors Council is specific for physicians, and they've actually been around since the 70s, really focusing on the public sector in New York. And they've recently branched out to the private sector with Allina Health out in Minnesota, where they organized the largest outpatient physicians union, as well as they also organize their inpatient hospitals, and it's about 120 inpatient physicians there at Allina Health, and so.
Okay. What did you have to do to get this off the ground?
Well, it started initially just having conversations with all different doctors and all different specialties.
Who initiated those conversations? I have a feeling it was you, Amber, right?
Some of them, but the very first, conversations I think were had between you and Jenna D. Ricklin, right? And some of the other internal medicine physicians,
There were a handful of hospitalists who got together because we were starting to feel like we didn't have a voice in our practice of medicine anymore. And we threw around the idea, hey, what if we formed a union? What does that even look like? And one of my good colleagues, Dr. Ricklin, who's one of the leaders within the union, called up Allina Health and got in touch with one of the people who had been in the media for Allina Health, leading the physicians union. And within a week or two, we were in touch with Doctors Council, and we started having a lot of meetings. I would say that I invested hundreds to thousands of hours to these meetings, plus conversations to say, hey, what can we do better as physicians, and what can we create within this union to make the practice of medicine better in Delaware?
Well, obviously you put in a lot of hours, both of you guys, to do this. No reimbursement for the hours, I take it, right?
No, not at all.
That's a good sacrifice on your part, so thank you for doing it.
And then after those conversations, just as like a functional structure, how you form a union, because we didn't know. We were a union professional. We've learned a lot in this process. Then we went through and had everyone who was willing to sign a card saying that, they're supportive, they're willing to vote yes. And once the federal government requires 30% of that body to have signed a card before they'll have an election. Our advisors at Doctors Council said you need 70%. So we had to get 70% of all the physicians who were eligible for this union in the hospital to sign a card saying, let's go for it.
And you got it.
And we got it. And then in our election, we had the same number vote yes.
Kudos.
And we didn't have them start signing cards until we knew we were at that 70% support. And so after that, there's a lot of negotiations that go on around what happens for the election. Because we're a group of inpatient physicians, we're not all at the hospital every day because we work shift work. And so then there was a lot of negotiations over, do you have an election one day or do you have it over the course of a week? So we had the election over the course of the week.
You have proxies you can send? Like if you're not there that week, you send a proxy vote?
No, some people flew back from vacation.
Yeah.
Wow.
And
that's impressive.
Both sides have somebody to verify people's identities, and so the administration from Christiana as well as the people from the union to verify people's identities.
Nice. So, now I understand, I think we talked when we were on break about if you work at least 20% of your time at the hospital in any capacity as a physician, you would have to join the union. That's a good rule too.
Yeah. So there's some very important pros to this because in reality, one of the reasons we wanted to form a union was to really protect the physicians at Christiana from any sort of repercussions, any retaliation, any sort of bad things happening to them.
Like what?
So,
well, specifically just for being involved in the union, right? So having that sort of security that, if there's some retaliation from administration because they don't like what you're doing, being involved in the union, that you have that legal protection from the National Labor Board. But also we wanted, that's historically a very important concept with unionization, is that everyone who fits that definition of that employee is part of it by default. And that provides protection for the individual employees, but it also provides a stronger union in itself, because you have the maximum number of people there discussing, negotiating, and hopefully supporting what the union does. There are states in which that's illegal. So those are called right-to-work states, and they have passed laws through their legislature that you cannot require somebody to be part of a union. If they say, yes, I work at the hospital as a 100% employed clinical physician, I don't want to be part of it. If you were living in one of those states, that would be absolutely fine. Delaware's not one of those states. And typically the blue states, the states that tend to vote Democratic, don't have those laws that allow people to opt out, because they support the strength of unions, and it's a very important dynamic, I suppose.
What if Christiana is to put up like a resolution or legislation in Dover that says they would not like this to happen, and it gets passed, then you're stuck, right?
Well, then they would be also fighting against our Democratic legislators, but also a lot of other unions that are not just this one healthcare union within the state, because a lot of the union laws are overarching to a lot of different workforces.
Got it. Before we close, is there anything you guys would like to offer or say that we haven't touched on or brought up?
Yeah, I think one of the ways that our union got started was us as physicians reaching out to other physicians that were in the process of unionizing.
Okay.
And so we, Dr. Haimes and I would like to offer the ChristianaCare PhysiciansUnion.org website as a place to contact us or our colleagues if other physicians have questions about unionizing their hospitals or outpatient organizations. We're happy to help.
We have a small social media following on ChristianaCare Physicians on Instagram, and so you can always find us there as well. Our biggest thing is we love to talk about this. We love to have conversations about how to change the landscape of healthcare, because healthcare has been dominated for a long time by the business aspect of things and by the dollar. And there's a lot of middlemen trying to take that dollar, and we want to protect our patients. We want to take care of our patients and stop the corporate greed. We've seen too many hospitals locally shut down recently. Hahnemann up in Philadelphia, Crozier recently, and we don't want ChristianaCare to be the next hospital to shut down.
Well, give us that website.
ChristianaCare
Physicians
Union.org.
That's pretty simple. All right, very good. Well, this has been a very interesting conversation, and I give you guys all the credit in the world for doing this and trying to get this all going. And it sounds like it's going in the right direction, and I sure wish you the best of luck. It's a little too late for me to worry about it, but I won't be joining any unions at any time soon. Soon to see the retirement on the wall. But I think a few things that you said here today piqued my interest, and one of them is better communications with the outside world, guys. You're not just a hospital. There's an outside world that feeds your hospital, if you remember that. Yeah. Okay, this is Dr. Nick Biasotto, who just finished a very interesting discussion with Dr. Bryan Haimes and Dr. Amber Higgins on the unionization in the hospital setting here in Delaware at ChristianaCare. Until next time, have a good day. Bye.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Minton. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.